All right. So now we're going to talk about um chapter 12. So when we're talking about um assessing a mom, right? Someone who comes in who's pregnant, their vital signs could be a little different than someone who isn't pregnant. So actually we expect the temperature to increase. Remember how we were talking about the pregnancy hormone, progesterone is released while you're pregnant and it increases during your course of pregnancy. Well, because of that hormone, we also see a slight temperature elevation in our pregnant patients. Um, Heart rate will also be 10 to 20 beats per minute higher than their baseline while being pregnant. And that's because we want to try as a pregnant woman to have more circulating blood to that baby. The blood pressure, though, will remain stable because of that hormone relaxin. But remember, we did talk about in the previous um lecture that hey, there is some trimesters where the blood pressure shifts. And just as a recap, right? We are talking about um when we're in that first trimester, right? It's typically that pre-pregnancy level, that blood pressure. But when we get to the second trimester, the blood pressure will decrease a little bit. And when we're in the third trimester, it will elevate a little. So just keep that in mind that there will be some differences, but in that initial assessment, especially when we first come in, we expect the blood pressure to be stable, and especially respiratory rate should always be pretty much stable. Then we're also looking at, right, their height and their weight. We want to make sure that they're gaining an appropriate amount of weight over the course of their pregnancy, right? Looking at the pelvis, like making sure everything's okay down there. Examining the fetus. Remember, the questions on your exam are always going to be priority related. And 99% of the time, it's going to be what should I do in this situation? It's going to be monitor fetal heart rate or check the fetal heart rate because we don't know what's going on with the baby. Unless the question says that the mother is in physical distress, which most of the time isn't, just as the mom comes to the hospital, and, um, we're looking for something to assess, we want to check the baby. And a normal fetal heart rate should be 110 to 160 beats per minute. The fundal height, right? We were talking about that in the last lecture, was that it should be equal to how many weeks gestation plus or minus 2, right? So if they're 18, we expect the fundal height to be 18 centimeters around, give or take, okay? It could be plus 2 or minus 2. And then we have some diagnostic tests as well that we need to look at, right? And if I'm a pregnant woman, right, and I'm coming in for tests, what sorts of things should I be looking for? Well, I should be looking at their CBC with differential. For a pregnant woman, the values slightly change. So it's going to be 11.5 to 14 for hemoglobin. For hematocrit, we're looking at 32 to 42%, whereas normally it's 35 to 45% for a non-pregnant person. The WBC count is actually 5,000 to 15,000, which is different than um, us typically. Platelets are actually 150,000 to 350,000, and RBCs are 3.75 to 5, which is still slightly lower than what we normally have. And that CBC with differential is going to tell us if they have infection and if they have anemia, right? Because we did talk about problems that can occur, and we talked about potential anemia as a result of being pregnant. Type and screen and antibodies, right? We need to look at that, especially we want to look at that RH factor, right? We want to see if it's negative or positive and look at their blood type. That's going to tell us a lot because we're going to be talking about a problem called RH isoimmunization, something like that. Don't remember that exact word, but there is a problem um, with this RH factor, which we'll see later. So rubella, because we need to check if the mom is immune. Okay, rubella can cause some severe side effects to the baby if they were to catch it while being pregnant. Hepatitis B is another thing that we need to check for. STI screenings, why, or STDs, because we need to make sure that they don't have any STDs because that could be transmitted to the baby during a vaginal birth. Some things will include like herpes, gonorrhea, HPV. I want you to know because it was on my exam that for syphilis, VDRL and RPR are two tests that you can do in order to detect syphilis. We're also going to look at cervical smears, pap smears. We're looking for cervical cancer, vaginal cultures, right, to make sure there's no like bacteria there, tuberculosis, HIV, torch screenings, which we're going to talk about, um, root B streptococcus, another type of bacterial infection that can cause birth defects. And we typically check for this between 35 and 37 weeks of gestation. We have this maternal serum alpha fetoprotein, which we usually do this earlier on in pregnancy. And you're going to see that most of the screenings that you're going to perform and tests that you're going to check for either neural tube defects or chromosomal abnormalities are going to be in that earlier stages of pregnancy. So between 15 and 20 weeks gestation, we do this alpha fetoprotein test to look for neural tube and chromosomal abnormalities. If the value is high, then that indicates that they have a neural tube problem. And if it's low, they'll have a chromosomal abnormality like Down syndrome. We're looking at HIV. The thing that I want you to know that for in New York is that even if the patient refuses, the mother refuses to do HIV screenings or testings, it is mandatory that the baby is to be tested after they're born for HIV. Even if the mother doesn't want that herself to be tested, the baby has to be tested. We're looking for urinalysis and cultures because as we were talking about, women are very susceptible to having UTIs. And you could, please correct me if I'm wrong, but I believe it's during that second trimester is where they're at most at risk for potential UTIs. Also looking at for gestational diabetes, renal disease, infections. And then we have glucose screenings because gestational diabetes can be a problem in pregnancy. And we usually do this for high risk patients during usually that 24 to 28-week period. And what we do is we have the first test, which is a 1 hour screening. And essentially, we're looking for a reading of 130 to 140 or greater. If they have that, they'll have to go for more diagnostic testing and come back again. If not, they're good. They don't have to come back for more testings. If they're above 130 to 140, you will need to know this. You will go for diagnostic testing for gestational diabetes. Diagnostic testing is a 3-hour diagnostic test where we give 100 grams load of sugar to the patient, but they're told to fast before they get this. So they stop eating and drinking at midnight before they take this test. They'll get the 100-gram load, and there's 4 readings that are going to be taken. If 2 of those 4 readings have higher than the expected value for any of those ranges, it means that they have gestational diabetes. So, for example, if their fasting rate is greater than 95, that's a problem. If they're after 1 hour of taking this 100-gram load, if it's greater than 180, that's a problem. If in 2 hours later it's greater than 155, that's a problem. And if 3 hours is greater than 140, that's a problem too. That's why they call it a 3-hour test. Okay. So you're definitely going to get a question like this. She's going to give you values. She's going to give you the 3-hour diagnostic screening, and she's going to ask you which of the following values, right, from each testing screening would indicate that this person has gestational diabetes. Or in addition to that, I think she even asked, how many readings do you need to know? Will let me know, hey, this patient has gestational diabetes. And that's if out of these 4, at least 2 are higher than the norm. So we have another really important rule, which will also be tested on, Nigel's rule, which is the estimated due date. Okay. So basically, this is when we're doing a little bit of math. So we look at the first day of their last normal menstrual period, and then we subtract 3 months, and then add 7 days. And then, obviously adjusting for the year. So let's just say their last period was January 3rd, 2023, right? The way we would see their previous due date would be we would subtract 3 months, and then we would add 7 days. Sorry, that should be 2022. So that would be, in this scenario, it will be October 10th of 2022 will be their estimated due date. Sorry, it would be 2023 because it's talking about we're getting the estimated date, but we're using the same year or the year ahead because we're finding the estimated due date. My bad. So you're gonna subtract 3 months, add 7 days from their last menstrual period, and then add the new year if it goes into the new year. So if it were to be in 2023, even though we're subtracting it, it would be like we're talking about 2022. We're not. We're talking about this is going to be their due date for 9 months from now. So that's how we do it. The same thing. If it were November 22nd, 2022 would be the last first day of their normal menstrual cycle. We'll subtract the 3 months, which means that we're talking about August, right? But that if that was the last day of the next menstrual period, we know that we're going to add 7 days. So that's the 29th. So that baby is going to be due August 29th of 2023, which would be 9 months later. That's how you do the math for this. And there's definitely going to be a question like that on the exam. Is there any questions about this?
Yes, can you just go over the wait, no, you didn't go over the gravida or the para yet, did you?
No.
Yeah. Okay, sorry.
Okay, yeah, I just wanted to make sure. Okay, so the math is good. So yeah, just make sure that you adjust the year accordingly. It's usually going to be a year up depending on, when uh their last period was. Um okay. So now we're going to talk about gravida and all of these terms. You're definitely going to be asked about this. So gravida is the total number of pregnancies, including your current one. A null gravida means they've never been pregnant. Prima parida means that this is their first time being pregnant. Multigravida is when they have two or more pregnancies. So gravida means it, like I said, total number of pregnancies, including the current one. So they could trick you and say, a mom, right? A pregnant mom comes to the clinic and tells you that she has two, previous children, each delivered by a single birth. Well, that would mean she'd be a gravida 3 because she would have had 3 pregnancies. See what I'm saying? So just make sure if it says pregnant woman, don't get confused. Para means a number of times a woman has given birth. So let's just say this a number of times a woman has given birth after 20 weeks. Okay. So we're gonna go over, some examples, but just know it's a number of times a woman's been pregnant after 20 weeks. There's multiple births in one event, and we're basically just looking at how many times they've been pregnant. It doesn't matter if it's twins, that's still considered one pregnancy. That's one para if it were twins. Then we also have TPAL, right? So, besides gravida, right, which is the total number of pregnancies, we're looking at how many term births. That's kind of like what the para is. So you could say G para and then add the numbers, or you could say GTPAL as another way to describe it. But she's gonna show it to you as GTPAL. So the T stands for term births. How many babies did this person have that were born after 38 weeks or more? Preterm, how many babies were born between 20 weeks and 37 weeks. Abortions is the A. Spontaneous, meaning it just happened or their choice before 20 weeks, okay? And then how many living children? So let's just say this was the question, right? A pregnant patient reports to the nurse in the clinic the following history, right? Now, this is a pregnant patient, okay? So we're already going to add one for the G. They had a vaginal delivery 2 years ago at 26 weeks gestation, and the child died at 2 days of age. Okay, so we keep that in mind. We say this patient also had a vaginal delivery 4 years ago at 38 weeks gestation, and the child is live and well. They had a spontaneous pregnancy loss 5 years ago at 8 weeks gestation, and they had an elective termination of pregnancy 10 years ago at 6 weeks. So, gravida means how many times they were pregnant. So, based on this, she's pregnant right now, and she's had 4 other pregnancies, which means the G is going to be 5. Term births, how many of those children were born after or at 38 weeks? 1. The P is for preterm. How many of these babies were born between 20 and 37 weeks? 1. How many abortions did she have, whether they are spontaneous or elective? 2. And how many out of all of her pregnancies, how many children are living and breathing right now? 1. The other one inside the stomach doesn't count, okay? Because they're not born. So it's just one living child. So you would write that as G5T1, P1, A2, L1, or sometimes it's like G para G para like G5 para 1121. That's another way of saying it. But I think she's gonna show it to you in this way. Is there any questions about this?
Actually, yeah, sorry.
Okay.
The term for term, oh yeah, I just answered my own question. It's only term births and preterm births, not anything that has to do like anything with like, oh, the patient lost the baby, anything like that, that would be considered the abortion.
Yes, spontaneous or elective is A. Yes.
Okay, and it has to be 38 weeks or more for it to be considered term birth. Yeah, okay, perfect.
Yes.
Thank you. Sorry.
No, that's good. I want to help you because you're going to see at least one question like this. So
Right.
this should
Thank
be
you.
the gimme question because it's like, okay, I just need to do the math and count some numbers. Remember, pregnant, look for pregnant because that's why this is 5 and not 4 because it includes the pregnant lady now. That's why I emphasize that in the beginning because that could throw you off if you're not like paying close attention. Because she could easily have made, I think she did it where she listed the different numbers like G this, T this. So she would definitely put an option as G4 with all of this correct, and that's because you would have forgot to put the pregnant woman. So just keep that in mind. Okay, so then we're talking about subsequent visits, right? So every 7 months, every 2 weeks during the 8th month, and weekly during the last month is how frequent they start to come, especially towards the end, right? So every month for 7 months, then when they get to the 8th month, every 2 weeks, and during the last month, every week. We're looking at weight and blood pressure, presence of edema. Lower edema can be normal, but upper edema would be abnormal. And we'll see why, because that could be a sign of preeclampsia. Okay. Urine dipstick. They could have sugar, especially if they're having gestational diabetes. Protein would indicate a kidney problem or preeclampsia. If they have leukocytes in a urine dipstick, that would say UTI. And nitrites, they are positive, is a bacterial infection, right? We're looking at that fundal height, the fetal heart rate, which we already talked about, and fetal activity, kit counts, okay? That becomes really, really important, okay? Especially, remember we were talking about that idea of quickening, they need to feel the baby. Well, you could feel it as early as, remember, 12 to 13 weeks, but by 20 weeks, you better feel that baby moving. You better have. And I believe it is 10 kicks every 2 hours. Someone can correct me. I think it'll be somewhere in my notes, but I believe that's what it is.
Yeah, that's correct.
Okay. Sometimes I'm saying things on the top of my head, so I don't want to say I know it and I don't. Um, but there's also danger signs of pregnancy, right? So what does that include? Well, if we're talking about first trimester, right? The baby's still forming. There's a lot of new things. Abdominal cramping, spotting, or bleeding will lead to miscarriage. Now, spotting could be common, but if it's heavy spotting and heavy abdominal cramping and a lot of bleeding, they're having a miscarriage. Indications of a UTI, painful urinations, flank pain, increased urgency. Know those three symptoms. She's going to ask you. Indications of a UTI. Diarrhea would also indicate infection in the first trimester. Severe persistent vomiting that happens during the first trimester. Remember, we said that HCG and progesterone are going to cause those increased GI symptoms and why they're vomiting. But if it's really recurrent, they'll have something called hyperemesis gravidarum, which is like they are vomiting a lot. That's not normal. And a temperature of greater than 100 during first trimester, not normal. Okay, you need to know that. For second and third trimesters, you need to know the difference between which trimester, because she's going to ask that. Second and third trimesters, right? Regular uterine contractions could be a problem, especially in that second trimester, right? If it's like 39 weeks and they're having contractions, they could be giving birth. But if we're talking about someone, at 20 weeks, that's not normal. Leakage and gush of amniotic fluid before 37 weeks, that could indicate preterm birth, not good. Persistent vomiting still is a problem. Fever is still a problem here. Absent or fetal movement, because I said after 20 weeks, right? We need to see that. If it's not there, no. Abdominal pain, problem. Vaginal bleeding, also a problem. Anything that's coming blood from the vagina, you could automatically know for both, problem. Changes in fetal activity for both first and second and third, all of those, yes, this would be a problem. Indications of a UTI, problem. Indications of preeclampsia, blurred vision, severe headache, epigastric pain, decreased urination, and edema of the face or edema of the upper extremities, problem. So if they say patient comes to the, ER, pregnant woman, and says, I'm having blurred vision, you want to test them and see if they have other signs of preeclampsia. And we want to get, urine dipsticks and things like that. If they have flushed face, fruity breath, rapid breathing, increased thirst and urination, hyperglycemia. If they're irritable, confused, lethargic, clammy, you could also use a little mnemonic tired, which stands for like tachycardia, irritability, restlessness. I think it's excessive thirst, and the D is diaphoretic. That could help you remember the signs and symptoms for hypoglycemia. Okay, so assessment of fetal well-being. Our priority is always going to be the fetus with 99% of the questions. I'm going to tell you which one is not a situation where the baby comes first. But let's talk about kick counts, right? It's the mom can do this herself. It indicates fetal well-being and it measures central nervous system status. Decreased movement is associated with chronic oxygen compromise. We need to have 10 movements within 2 hours, okay? We must have that. Um, Also, especially after getting into that second trimester, right? Um, Patients should be in a lateral position. Okay, this is what we teach them how to assess their kick counts of their baby. They're gonna lay on the side. They never lay on their back anyway, but we're gonna tell them to lay on their side, right? They should have an empty bladder and they should have ate. Okay, so we don't want the stomach to growl or anything like that. We don't want that kind of movement. We want to feel the baby. We want to lay in that position for 2 hours straight. And if the mom doesn't feel any fetal movement, or does not feel 10 fetal movements within 2 hours, they need to call the doctor and the patient must go in for a non-stress test. Know that. No fetal movement, call a doctor, and patient's going to go for a non-stress test. Remember that. Remember that. It's going to be on your test.
Are you sure? So,
Hmm.
I have a question. So, when it comes to a lateral side, right, the left is more recommended than the right. So, if it's a question and then they wasn't specific about like just lateral, but then they asked us if it's the left lateral, and then the next option is the right lateral, then the better answer will be the left lateral.
Unless your professor said which position would specifically be better, I've never seen one where it's like they have to be on the left or the right. Did your professor say like that it's best to be on the left side for a pregnant woman?
No, but I seen a question in the API book, and then it asked about it was a select order apply about the kick count, what the patient have to do while they doing the kick count, and one of the options was the patient have to be on their right lateral side. But the answer that wasn't part of the answer because they said they're supposed to be on the left lateral.
Oh, I don't remember her asking anything like that, but I would know it just in case, but I don't think she'll give you a side. But since you said if they said you said in the textbook they said the answer was left for the ATI, they said it was left side.
Yes, they said it was left lateral.
Well, I guess it doesn't hurt to know it, but I don't think she would ask you which side if she didn't say it herself. Um, the idea though that I saw in her exam that I remember was, right, the mom's doing an assessment and feels like 8 movements in 2 hours. So what should she do? Nurse should tell them, call your doctor and you're gonna come in for, or it'll be like come in for a non-stress test and call your provider, something like that. Um, okay. So there's also a bunch of tests that we're gonna do besides fetal quick count. That's one of the most important things that they need to do. But we also have transvaginal like ultrasounds. We're looking this tells us the presence and the location of a pregnancy. It could detect if there's more than one fetus growing in there. Um, the gestational age, I would know this, is that basically you look from the crown rump or the top of the head to the base of the spine for the length measurement, and it's most accurate between 6 and 10 weeks. That's how we determine gestational age of the fetus. I would know that. I think I saw that somewhere on one of my quizzes, and always assess for fetal heart rate activity. For second and third trimester, this becomes really important because we're doing transabdominal, okay? We're not going to put anything into the vagina now. We're going to keep it on top, okay? And we're looking at, it's going to tell us a lot. It's going to tell us about their fetal anatomy, if there's defects in the heart. It's going to look at fetal viability, right? Their life, the fetal heart rate, the gestational age, their growth, the amniotic fluid volume. We talked about the volume needed. Make sure you know that. Location of the placenta, fetal presentation, how they look, which direction they're in, okay? And we do this at 20 weeks. Know that transabdominal, we're doing at 20 weeks. Doppler flow studies. This is another thing that we could do. And it assesses the maternal fetal blood flow from the umbilicus and the placenta. Okay? If this line, right, this is basically movement of the baby and what's going on in here, right? That fetal blood flow, if that line is not wavy, it's just straight and it's flat, that means blood flow has been compromised in a Doppler study. Now, here's some things I know 100% is going to be on your test. First, the alpha fetoprotein. We already talked about, right, that we typically do it. It's a quad screening. We do this between 16 and 18 weeks, okay? And it's a glycoprotein that we're looking for. We draw blood from the patient and we look at the protein level. We look at this glycoprotein. If it's high, right, neural tube defect. If it's low, risk for Down syndrome. Know this. And the mother can decide to have more diagnostic screenings after. So AFP, remember, it's not a diagnostic test. It's a screening. Okay? This is not diagnostic. It screens to let you know the risk of having either a neural tube defect or Down syndrome. It is not diagnostic, okay? But know that it occurs between 16 to 18 weeks and what it does, all that stuff. But just know definitely for sure that it's also not a diagnostic test. It's just a screening. Then we have a non-invasive parental testing, another screening test, which is performed at 11 to 13 weeks gestation. And it used to look for Down syndrome. Okay, so this is a little different. Okay, this one's not looking for neural tube defects. We're looking for chromosomal or we're looking for Down syndrome. Okay, so there's a few ways that we could do this. We could do marker screenings through counts of the DNA. And so that's a blood test or a neutral translucency exam. This is basically looking at the thickness of the fluid at the bases of their necks for children, and that lets us know if they have a chromosomal problem, okay? I know she 100% asked about this one. And remember, it's a screening. Doesn't mean they have it. It just shows that they have an increased risk. Now, amniocentesis. This is when we remove. Anything that you see synthesis usually means you're removing something, and the word in front of it lets you know. So amniocentesis is you're removing, right, amniotic fluid from the amniotic sac. Usually do this between 15 to 20 weeks. Know these weeks. And this one tells us about chromosomal abnormalities, neural tube defects, and inborn errors of metabolism. Okay. It is diagnostic, not a screening, it's diagnostic. It's going to let us know if they have one of those things. But here's the problem, right? If we're putting a needle into a female's stomach to remove this fluid, we have risk for spotting, cramping, amniotic fluid leaking, um, chorioamniotis, which is basically like an infection of the sac and the fluid, right? Chronium, amnion, they're both the sac, so an infection of the sac and the fluid, and potential fetal demise, okay? So, how do we do nursing management? You must know this. You need to get informed consent. Any procedure that's invasive, you need informed consent, right? Empty the bladder. Okay, have them in a supine position with a wedge under their right hip so that they're not fully on the back, because we said laying on your back can compress blood flow to the baby. We're looking at baseline vitals and fetal heart rate assessment for 20 minutes. We want to get that assessments, okay? Remember, priority assessment is fetal heart rate. We're also looking at the moms, but we need the baseline vitals for the baby, okay? Because we are putting a puncture into the mom's stomach that risks potentially blood from the mom to get to the baby, which means that if the mom is Rh negative and that baby is Rh positive, we give Rogram, okay? Because we don't want, right, the baby or the mom to start forming all these antibodies, and then it could complicate future pregnancies, okay? So, very bad, okay? The next diagnostic test is the chorionic villus sampling. Now, this is used to detect only chromosomal. So, amniocentesis can do chromosomal and neural. This can only do chromosomal. Okay. Now, it's also a needle aspiration, and we get this from the placenta at 10 to 13 weeks. Know these weeks, right? Nursing management. Once again, we're putting a hole, we're puncturing with a needle. So there's bleeding, cramping, risks of an spontaneous abortion, as well as chromoamniotis, which we already said is basically an infection of both the sac and the fluid. Remember, administer Rogram to an Rh negative mother post procedure if that baby is Rh positive. Non-stress test. Remember, what did we say? If they don't have 10 fetal kicks in 2 hours, then we're gonna notify the doctor and send them for a non-stress test. Now, non-stress test is gonna tell us a lot of really important things. It's going to tell us if this baby, what this baby's heart rate is and if they're having accelerations. Accelerations are really important because they indicate intact central nervous system, okay? Acceleration patterns are affected after 28 weeks of gestation. Now, you need to know these terms. Reactive, 2 or more accelerations within 20 minutes, at least 15 beats above the baseline, and lasting 15 seconds, okay? Because remember, when the heart rate increases it should increase when the baby's moving. That's why we have the fetal counts, and that's why we have the non-stress test when we notice that the fetal counts are down. Non-reactive means that there's insufficient amount of accelerations over 40 minutes, okay? And if it's non-reactive, further testing is needed with a biophysical profile. Know that. She's also going to give you diagrams, so look at those examples that she's provided you in your slides on what those look like. So also for nursing care, right, we have the monitor that's watching them, and tell the patient during the non-stress test to click the button every single time they feel the baby move. So reactive stress tests, just so you could see, every one little block on that fetal heart rate strip is going to indicate 10 seconds. So if it goes in between 2, like this little rump right here, we know it's already getting past that 15-second mark. Now, the other thing is that every single line is 60 seconds. What we want to see is that this is around their baseline, right? This is about 130 beats per minute for that baby. When they click it, we want to see that the fetal heart rate goes up at least 20. So we're looking at 160 right? When she clicks it, oh, their highest was 160. That's great. Okay. So we know that when they are having fetal movement, that baby, they are having accelerations because their heart rate is going up more than 20 beats per minute. So, like I said, we want to see it go up. We want to see the accelerations, and you can mark it to see where it was, like that average, or it's hard to see. I don't know why it's not letting me zoom in right now. But where that little rump is, wherever that average is what we're doing, and the highest was 160. A non-reactive stress test. Oh, well, I don't know why my notes aren't going in right now. Will be a flat line like this, where even when she's not really feeling anything, and when she is, there's no accelerations, right? So there's no heart rate change. The heart rate should change. And this is just a flat line. So the heart rate is steady, that's non-reactive, and now we need to send them for a biophysical profile, okay? Any questions about like a reactive versus a non-reactive stress test? Definitely know how to count it. Definitely know how to do that because you're definitely going to at least get one question like that. And know if it's non-reactive, then you need to send them for a biophysical profile. Now, a biophysical profile is an ultrasound after 24 weeks gestation, right? Indications, non-reactive, non-stress tests. If they have suspected polyhydramnios, which is basically, not enough amniotic fluid or too much amniotic fluid, suspected fetal hypoxia, as well as premature rupture membranes. But she did ask, right, besides knowing that when you have a non-reactive stress test, you want to do a biophysical profile, what the parameters are. And these are your 5 parameters. This is what the biophysical profile looks at. It looks at fetal movements, fetal tone, fetal breathing, fetal movements, and amniotic fluid volume. And here's the scoring. She also asked about that, right? 8 to 10 points. If that's what you get, awesome. If they tell you 8 to 10 points for a biophysical profile, awesome. That's really good. 6 points is suspicious. Need to know that you have to repeat in 24 hours. Less than 4, delivery of the baby is considered, and we need continuous baby monitoring. If it's less than 2, we need a prompt delivery of the baby. You must know these because she's going to give you the value and she's going to ask you, what does that mean and what do you do? Okay. Now, I'm not going to go over the discomforts of pregnancy so much because you do have them in your ATI book, but just know, right? I'm just going to list them and then you can look into the client education in your ATI book. That's going to be page 23. But for first trimester, we're looking at discomforts to include nausea and vomiting, breast tenderness, urinary frequency, and fatigue. Whereas for second and third trimester discomforts, we typically see is heartburn and indigestion, constipation, urinary frequency, especially in that late trimester, remember with that lightening, right? So the heaviness drops from being upwards to more on the bladder, hemorrhoids, varicose veins and edema of the lower extremities, Braxton Hicks contractions, leg cramps, and supine hypotension. Okay. Those are some of the things that you could see as discomforts. So please know that and no patient teaching for those. Okay. So health promotion. What are we going to teach our patients, right? Well, they need to avoid all over-the-counter medications. Remember, I always talked about in pharm, no drug is really safe for a baby, even if it's over the counter. No alcohol, no tobacco, no substance abuse, like none of that. We need to teach them about strategies. Avoid hot tubs and saunas because they can affect the temperature of the amniotic fluid. I highlighted that because she did mention that. She should exercise for 30 minutes a day. You, as a pregnant person or any pregnant person, they can have sexual activity as long as there's no complications, stated by the doctor. 8 to 10 glasses of water a day. Immunizations, we talked about, right? We need to do certain diagnostic tests, right? Like hepatitis, Tdap, rubella, things like that. But pregnant women cannot get live vaccines. So what are those? Well, hepatitis B, influenza, tetanus, diphtheria, rabies, and COVID-19 are all contraindicated because they're live vaccines. Know that. Sorry. Yeah, no, sorry. These are good. These are good. I read that wrong. These are good vaccines because they're not live. Everything that's live is including influenza, the live vaccine or the nasal spray, um, measles, mumps, rubella, varicella, tuberculosis, and typhoid. Those are all contraindicated, but these are not live, so you can give them. These are live, so you can't give them. Sorry, that was my fault. If there's also a book, there's also a box in your textbook, 12.5, that shows these. We already talked about fundal height, so I'm not going to really get into that. We already did that, but definitely know it and know, right, that it should be typically what the gestational age is, around plus or minus 2 centimeters. Okay. So now we're going to go into 19. This is more about the different types of problems that we can have during pregnancy and what do we do. There's definitely going to be a decent amount of questions on these. So we have spontaneous abortion, which is very common in early pregnancy. Remember, we were talking about dangers in pregnancy. We were talking about that first trimester, and we were talking about, right, abdominal cramping, bleeding, excessive spotting, not good. Okay. Spotting can be normal, not unless it's blood and it's a lot. Okay. Um, if it's, less than 20 weeks gestation, chances are the baby's not going to live. An abortion, right, is considered also a spontaneous miscarriage or induced. A stillbirth is the loss of a fetus greater than 20 weeks. So anything less than 20 weeks is considered an abortion, either spontaneous or an elective procedure, right? You choose. Stillbirth means you lose that baby who's older than 20 weeks. So when do we see spontaneous abortion? We're talking about, right, something happening to the fetus in less than 20 weeks. Usually within the first 12 weeks, we will see this. Usually severe chromosomal anomalies are the cause, and as well as decreasing HCG levels. Remember, in that first trimester, we said it's so important to have elevated HCGs. They must double, right, every few days. So if not, they can have an abortion. So, what are we looking for if we're looking for potential abortion? We're looking for bleeding versus spotting, right? Is it spotting light blood or are they bleeding? Is it like a period? Ask them that. Are you saturating the pad? They could be losing the baby. Pain, they can have some pain, but if it's really bad, problem. Cramping and contractions, right? Are they cramping a lot? Does it feel like a period? Can be a miscarriage. Passage of POC or products of conception, okay? Anything other than blood coming out of the vagina. Vital signs, right? If the mother's bleeding, we want to get vital signs first, then treat the pain. If the mother comes in, right? This is one of those situations. The mother comes in and they're bleeding on the vagina. Or yes, we're gonna look at the baby, but we need to get the vitals first of the mom because there's also a problem here too. So if the mother comes in with a lot of bleeding, we don't know if she's having, an internal hemorrhage either. So we want to get the vital signs first, then treat the pain while also monitoring the baby. Okay. And we also want to look at the amount, the color, and characteristics of the bleeding. So management includes, right, continued assessment, psychological support, especially if they end up losing the baby. HCG levels, right? We need to look at that. Making sure they're doubling, right, every 48 to 72 hours. That hemoglobin, that hematocrit level, okay, we need to make sure that's normal, right? If it's not, they could be hemorrhaging, right? We need to look at that. And if they're Rh negative, without sensitization, meaning like they haven't been forming antibodies. If that didn't form yet, we can administer Rogram. With, or, in this situation, like I said, if it's R negative and the babies are positive. Okay. So then we have placenta previa, another problem. It means after birth or placenta first. So basically what happens here is that the placenta is improperly planted over the cervix during the last 2 trimesters. And it should be, know this, in the upper third of the uterus. But if it comes out, it could lead to fetal demise. And you could see how they're not in these pictures in that upper third of the uterus. So you need to know these symptoms. She's going to ask this. The uterus is going to feel soft and it's not going to have contractions. Okay, there's going to be Painless, painless, bright red bleeding occurring after 20 weeks. Know that it's painless red. Okay? For management, right, we're looking at the bleeding and degree. Okay, but the baby is a priority here because it's not the mom that we're worried about in the placenta previa, it's the baby. We want to look at the maternal's vitals, vaginal bleeding, and all that, but the baby is a priority here in this situation. Okay, know that. When they get to go home, the management is limited activity with pelvic rest. Nothing in the vagina. Nope, this is where anything gets contraindicated, okay? Daily fetal kick counts. No bending, no straining. We don't want them moving much at all. Assess uterine activity daily. And if there's any position that she feels like she might give birth, she needs to call, right? Because she can't give a vaginal delivery. This must be a cesarean delivery, okay? Know this. Placental abruption is an emergency, even worse than placental previa, okay? This is a premature rapid separation. So this is when the placenta actually separates from the uterine wall. Either all or part of it. Now, know the maternal risk because she did ask a question about this. So risk would be maternal hypertension, blunt force trauma to the abdomen, maybe like falling, cocaine or methamphetamine use, cigarette smoking, multiple fetal pregnancies, so if they have twins currently, advanced maternal age, so over 35 years of age, and a high parity or a gravida of 6 plus. Indications, okay? You must know. I highlighted these because these are the most important ones, okay? It's sudden, intense, tearing, burning pain, right? Compared to placenta previa, which was painless, this is very painful. Okay? They have a high resting tone. They have an increased abdominal girth. The uterus is rigid, unlike placenta previa, where the uterus is soft. Okay, we're going to have in a placental abruption, a port wine colored amniotic fluid. And we're going to have the baby's most likely going to die. So this can be catastrophic. The priority when this happens is the mom. The mom is the priority. And what we're going to do is give a rapid cardiovascular assessment of the mom first, then the baby. And we're going to give the mom 2 large bore IV lines for fluid replacement, okay? So priority for placental abruption is the mom. For placenta previa, the baby. Know that, okay? And we also have some diagnostic and labs that we can look at. We already talked about the CBCs, fibrinogen levels, because of clotting, prothrombin activated partial thromboblastin time, also coagulation, especially if they need some sort of surgery, a cross match, type and screen for blood transfusions, a non-stress test, right, especially in this situation because it could lead to fetal demise, and a biophysical profile, right, if it's a non-reactive, right, non-reactive, non-stress test, they're going to go for that biophysical profile, right, and a score of less than 6, not promising. We need to know the risk factors, right? In that rapid assessment, we're looking at the mother's vital signs, okay? The pain and bleeding, and then last, that fetal heart rate, okay? So the priority is going to be in the question is placental abruption, assess the mom's cardiovascular status or assess the mom's vital signs. So management, right? Lateral side, okay? Maternal vitals and oxygenation saturation. Then fetal monitoring, then a Foley, okay? And then we're looking at the fundal height, things like that, okay? This is just a little chart from your textbook, a 9.1 that like describes difference. So don't know the differences between placental previa versus placental abruption. Any questions?
I have a question.
Okay.
For spontaneous abortion, what would be like the prioritization of care? Would it be like the max one?
Like who you would prioritize in the situation?
Yeah, because that was one of the outline that she wrote.
The baby.
Oh, the baby? Okay.
Everything except placental abruption.
Okay, thank you.
Yeah, it definitely can be tricky, but it's just the way to go because in this situation, the mom's fine, right? They might have psychological distress here, but like in terms of like what's going on health-wise, like who's gonna be at risk for dying, it's the baby, not the mom right now, unless for some reason that hemorrhage is ridiculous, But if they said, spontaneous abortion, it's the priority here is going to be monitor fetal heart rate. Placental previa, monitor fetal heart rate. Placental abruption, monitor maternal status. That's where we start to separate. Same thing here, right? We have hyperemesis gravidaeum, right? Which is this persistent, uncontrolled vomiting, right? We typically see this in first trimester. Because after that first trimester, what happens is that HCG is supposed to be high. That's why they do get nausea and vomiting, but it continues to stay high after that first trimester, and it could continue throughout the whole pregnancy. I've heard people say they had this. It's terrible. It's like you think morning sickness is bad for pregnancies. This is like consistent vomiting, like 24/7. Now, I made this cute little like mnemonic for myself when I was studying, and I called it DO for the characteristics of hyperemesis. So the D stands for dehydration, the E stands for electrolyte imbalance, and the W stands for weight loss, which will be greater than 5% of the pre-pregnancy body weight. Okay, I would know this. So another thing is that because of all this vomiting, right, because of potential electrolyte imbalances and dehydration that the mother might be experiencing, their baby's at risk for abnormal development, in problems with their growth and hypoxia. Okay, so we want to have we want to manage the labs and diagnostic tests. Okay, we need treatments, right? Vitamins. First line is that we want to give this one paroxetine, which is you take it with a sip of water at night before bed on an empty stomach. We could also give vitamin B6 with doxylamine or that. And we could also give Zofran. Those, you need to know which medications you can give, as well as promethazine. Those are some of the medications that you are going to be able to give as a nurse. And basically, promethazine is going to help with the nausea. Paroxetine and all that also is going to help with nausea and vomiting. And Zofran, but the first line, remember, first line will be paroxetine. That's the first one you want to give first. And we give it with a sip of water at night before bed on an empty stomach. We also have to worry about, okay, right, we have to look at labs. We need to look at those electrolyte imbalances, right? We want to look at ABGs. And then we're also going to be thinking about, okay, if they're still having this, we need a lot of fluid replacement and a lot of electrolyte replacements, depending on which ones become problematic, right? What becomes really important, yeah, we're looking at liver enzymes and all of this stuff, but electrolytes, metabolic panels, CBCs are the things that we really need to look at, okay? And also, urine specific gravity, we do expect that to be greater than 1.025. Why? Because they're dehydrated, which means whatever they pee out is going to be highly concentrated. In patient nursing teaching, if someone's throwing up, we're putting them NPO. No, not even ice chips for 24 to 36 hours. Know this. Know that we can give IV fluids and antiemetic. So we're going to start with isotonic solutions like 0.9% normal saline. And remember we said the first line medication was pyridine. Daily weights, right? Because they can lose greater than 5% of their pregnancy weight. Uterine and fetal monitoring, right? Always a priority. And comfort measures. This is all the care that we can give. The priority is still going to be the baby, but here's just some other things that we need to do. Now, if it said the mom were going into hypovolemic shock, then it's the mom that we're having a problem with, right? But it's not going to say that. It's going to say that the mom has, hyperemesis gravidaeum. What should I be looking at, or what sorts of lab values, what sorts of nursing management? These are the things. But if it asks for priority, it's going to be the baby. Hypertension in pregnancy, another big problem. Preeclampsia. This is when we have a blood pressure of greater than 140/90 after 20 weeks gestation, accompanied by proteinuria, so protein in the urine greater than 0.3, and a 24-hour urine dipstick, which tells us that it's a 1+ or more. Okay, if we see that, they have preeclampsia. Let's see. The goal is to prevent seizures, okay? So, because what happens is when they have preeclampsia, it can go into eclampsia, which is generalized seizures. So, what happens in preeclampsia is that we have vasodilation, which is basically causing decreased cardiac output and decreased perfusion, right, to every organ. So, if every organ is affected, that includes liver, brain, placenta, lungs, kidneys. And I like to think for preeclampsia, the pre, right? PRE, The P stands for proteinuria, the R stands for raising blood pressure, and the E stands for edema. Those are characteristic manifestations of preeclampsia. Manifestations, right? We already said hypertension and proteinuria, epigastric pain, headaches, visual disturbances, blurred visions, brisk deep tendon reflexes, decreased urine output. Why? Because there's that hypoperfusion, okay? There's lack of perfusion, there's cerebral potential hypoxia, which means headaches, visual disturbances, things like that. Increased sodium, BUN levels, things like that, and upper extremity edema. So the way I like to look at it is by each system. So the brain, right? Are they having headaches, visual disturbance? Are there deep tendon reflexes out of range? Lungs, are they having any difficulties breathing? Chest pain. Liver, are they having any abdominal pain, especially in that right upper quadrant? Kidneys, are they having any change in urine output, right? The urine will be more concentrated and the urine output will decrease. We'll have proteinuria. Placenta, is there a decrease in fetal movement because of that hypoperfusion? And generalized upper and lower extremity edema. Now, because of the placenta having hypoperfusion, we have risk for, I forgot what this stands for, but it's a problem with growth. Abruption and fetal hypoxia. I think it's like intrauterine growth restriction. I think that's what it means. Labs, right? CBCs, electrolytes, renal panels, livers, urinalysis, right? Especially because we want to see if there's proteinuria, right? We know that's one of the characteristic symptoms. And what do we teach them? We're going to teach them activity restrictions. Don't get up too much. Put them on the lateral side always. Adequate fluid intake, right? To increase that perfusion. Fetal activity, priority. Blood pressure twice daily. Look at their weights, their urine dipsticks. Remember, we said if they have +1 on that or more, also indicative of preeclampsia. Diet, right? We don't need to have a sodium restriction. That's not the problem. But we need to have a high protein diet for this and a high fiber diet, right? Because in proteinuria, they're losing protein, so they need protein in the body. And increased fetal surveillance with non-stress tests and biophysical profiles, okay? There's more, right? So priority, right? They don't move too much, and we need to really watch the baby and things like that, right? But there's also really important medications, and she's going to ask you about magnesium sulfate. This is what we give to prevent the seizures, to prevent it from going to eclampsia. So, always anticipate that you're going to give a loading dose of 4 to 6 grams, an IV of 100 milliliters of normal saline. Then we're going to give a maintenance dose of 1 to 2 grams per hour by bolus and then IV maintenance. Know this. She's going to ask you it just like this. Normal side effects with magnesium sulfate are feeling heavy and hard to move and sweaty and flushing. This is
Wait,
normal.
yeah, sorry. You said access about the loading dose of 4 to 6 grams in IV 100 millimeters of normal saline.
Yes, she's going to ask you these like what to
What
do.
to anticipate?
Hmm?
Is she going to, you said she's going to ask us what we have to anticipate for a patient who have preeclampsia?
If we're going to give them a magnesium sulfate, what do we anticipate? Like, how is it going to be given?
Okay.
Yeah, and this is that 100% going to be there. Also, what's the normal side effects versus what isn't the normal side effects, and what do we give if they have toxicity? There's definitely going to be at least 2 questions, 2, 3 questions. So, right, normal side effects, feeling heavy, hard to move, sweaty, flushing. Toxicity. So magnesium sulfate slows everything down. Remember that. So you're going to have a decreased urine output or oliguria. We're going to have a respiratory rate of less than 12 beats per minute. There's going to be cardiac arrhythmias and EKG changes. High magnesium serum levels. A normal therapeutic level is 5 to 8. Above 8 is toxic. She could also throw that at you and just say, oh, they're doing, a blood work and the magnesium level is 9 mgl/dl. Then you have to know right there from that, hey, I'm talking about magnesium toxicity, right? And she could say, what do you expect to see? You expect to see all these signs that we talked about, plus absent DTRs because things slow down, meaning there's no deep tendon reflexes. Interventions, priority. This is exactly what you're going to do. If it says it's toxicity, you stop the transfusion of magnesium and you give calcium gluconate of 10 milliliters of 10% solution infused over 3 minutes and notify the doctor. This is your steps 1, 2, and 3. We can also give hydroxyline, which is actually going to help decrease the blood pressure. Labetalol is safe to give to help decrease the blood pressure, and nifedipine. But the problem with nifedipine is that even though it decreases uh the blood pressure, it does it very quickly, and it also increases urine output very quickly. So they could have a very quick feeling of dizziness. So we need to really be careful with that. And remember, calcium channel blockers, things don't go away, right? What do we got to look out for? Well, I know calcium channel blockers, they decrease blood pressure, which means dizziness. Oh yeah, I remember I was telling you all that really two major signs and symptoms for adverse effects regarding calcium channel blockers are lower peripheral edema and as well as potential gingival hyperplasia. So, those are some things that we're going to also look out for, right? And that it also stops preterm labor. So nifedipine is very good. We're going to administer 10 to 20 mg orally for 3 doses, then every 4 to 8 hours. I don't remember her asking the specific like milligrams for this, but I would just still know it. But the best control is the calcium channel blocker. So if they were to ask a drug of choice for blood pressure control, it would be nifedipine. But if it were to ask what are the 3 ones that you can give, it's hydralazine, labetalol, and nifedipine. But nifedipine's a drug of choice. We can also give furosemide for edema. And remember that it reduces BP faster and it increases the urine output, okay, which is very good because remember, someone who has preeclampsia has a decreased urine output. Okay, so the delivery, always we want to have a vaginal birth. This is the only cure for preeclampsia. If a mom has that, the only cure for it is a vaginal birth. That's it. That's the only way. Once that baby is out, it's gone. The preeclampsia is gone. What's the priority? Fetal heart rate first. Then we can do all those things, right? The bed rest, lateral sides, a dark, quiet room with seizure precautions, monitoring the blood pressure, right? Reflexes, intakes and outputs, whatever, right? All the stuff that we need to be doing. But priority, fetal heart rate. We also have blood incompatibility or ABO incompatibility. So this is when, let's just say the mom is type O and the fetus is type A, B, or AB. And when that happens, it could have an ABO incompatibility, and that's usually because the father is either A, B, or AB. So, essentially, one of those anti-A's or anti-B's are going to cross into the maternal blood, and it's going to hemolyze those fetal red blood cells, okay? Which basically could cause hemolysis or breakdown of those red blood cells, right? Because of that ABO incompatibility, which means, what do we watch out for? Jaundice. Okay? We watch out for jaundice. And we have another type of blood problem, which is RH isoimmunization, where the mother is RH negative and the fetus is RH positive. She just asks you, one of your questions is going to be like, how would I know like the patient could be at risk for RH isoimmunization, and you need to know that the mom is RH negative and that the fetus is RH positive. I already know that's going to be on test. I know that was on mine. So basically what happens here is that when the mom's Rh negative and the baby is Rh positive, the mom is creating antibodies that are going to go against the baby's blood factors. So when that happens, we're going to give Program. Okay? So we give Program as prevention for complications in the future. But here's how it's going to run, right? First pregnancy, if it's an Rh negative woman and she gets exposed to an Rh plus fetal blood, usually inherited from the father, the mom becomes sensitized, okay? Which means that the body's like, uh-oh, I recognize this. In subsequent pregnancies, right, with 8+ fetus, it increases the maternal antibodies even more. And those can cross that placental barrier, attack and attach to those H plus cells, and it can cause the fetus to have hemolysis, like fetal hemolysis of the red blood cells, and anemia. So essentially, what the body does to compensate this in the fetus is, okay, wait a second, if something's trying to attack my red blood cells, I'm going to make a bunch of more red blood cells, which turns into something called erythroblatosis fetalis, which is an increase in immature red blood cell production. Um, and essentially, it's because all of that extensive hemolysis, um, right, makes the body react and have the baby produce more red blood cells. But in return, there's a lot of bilirubin that is not able to get conjugated because remember, when red blood cells break, they release bilirubin, and the liver can't excrete it and do what it needs to as quickly as the red blood cells are being broken down. So we have risk for hyperbilirubinemia, which can also lead to jaundice. So babies who have developed a Rh isoimmunization have a great risk for jaundice. If there's any indication, like I said, like in that scenario with the chromoamniocentesis where we removed fluid from the stomach, we believe that the blood's missed, we give Rogram. Now, here's other indications where we can give Rogram. So she's going to ask about all of these different things I'm talking about. She definitely gives a few questions on this topic. It's very important for her. So, in that first prenatal visit, right, we have maternal blood type, potential maybe ABO incompatibility or an Rh factor. What we're going to do is get her blood, get all of that, the type and screens, and we're going to look at this Rh antibody titer. It's called an indirect Coombs, right? So it measures the antibodies in the blood. If it's negative, the indirect Coombs, that means there's no sensitization, meaning no antibodies forms. If it's positive, that means that there's antibodies formed against those Rh positive red blood cells. And then what happens is that destruction of the red blood cells occurs, and that can become a problem, and we need even more increased surveillance to make sure the antibodies don't get too high. When we hit 28 to 32 weeks of gestation, the indirect Coombs gets repeated again. Okay, especially if the Rh negative mom had if they had a negative Rh indirect Coombs at the first prenatal visit, right? So if it said, hey, they were negative, they didn't have antibodies, we want to make sure, right? Because if they were positive, there's not much you can do after sensitization happens. But if it's negative, that means we want to just double check with, especially with that Rh negative, Rh positive baby, we need to be careful. If it's negative again, right? And there's no antibodies formed. We can give Rogram of 300 micrograms, which prevents formations of active antibodies. And it's temporary. Know this, temporary passive antibodies. That's what Rogram is. It provides temporary passive antibodies against the Rh factor to not make harmful active antibodies that can hurt the fetus. If it's positive in that second time, right? If it was negative the first time and we take it again at 28 to 32 weeks and it's positive this time, that means there's antibodies present. There's not much that you can do other than repeating it and monitoring. That's just because Rogram's not going to do anything. It's supposed to prevent antibodies, yet now there is. So,
Okay, Alicia, I have a question. So basically, in the first prenatal visit, that means that they're suspecting that the mother have the Rh negative, but they are not sure yet. So they do the indirect Coombs test, and then when she comes back, and then they do the test, and it comes out negative. That shows that she have the Rh negative thingy. So they have to give Rogam. Or I'm confused about the indirect Coombs test. I don't know.
okay. So, when they go to the first visit, right? What they're going to do is they're going to look at the blood type of the mom and they're going to look at the Rh factor. Okay? They're going to test for both of those. If that Rh factor comes back negative, that means the baby might be positive, okay? Because we're going to take a blood test. We don't know if the baby's positive. If we know if the mom's Rh negative, there's a possibility that that baby could be positive. So we need to do an indirect Coombs to determine if there's any sort of antibodies forming, because we can't directly test that from the baby yet because we can't get to the baby's blood. So right? If we take the blood work, it shows that the Rh factor of the mom is negative. We're going to do an indirect Coombs on that initial visit. That indirect Coombs, if it comes back negative, that means there's no antibody formation, right? There's nothing going on in the blood to indicate that there has been a reaction between Rh negative mom and a potential Rh positive baby. If it's positive, that means that antibodies formed, that that baby is Rh positive, and now it's basically the baby's blood cells are going to start being destroyed by the mom's antibodies, and there's really not much that we can do other than monitoring to make sure that those antibodies get too high, but we can't give them Rogram. If it's negative, right, and we know that mom's Rh negative as well, we're going to repeat the negative Coombs at 28 to 38 weeks, 28 to 32 weeks gestation. So that Rh negative mom is going to go through it again. If the test comes back negative, the indirect Coombs again, right? Just like the first time they took it, we're going to give Rogram on the second time. If it comes back positive on that second attempt, once again, there's nothing that we can really do. We can just watch and monitor. So essentially, we're only going to be giving them an indirect Coombs if when we, at that initial visit, if we determine the mom's Rh factor is Rh negative, because we can't get blood from the baby to determine whether or not that baby is Rh positive. Does that make sense?
Oh yeah, so the indirect Coombs is used to detect the antibodies that's being produced when the mother have the Rh negative. So in the first visit, they don't find no antibodies. They decide to come back for the second visit, and then during the second visit, when they do the test and they find out that there's antibodies created, that's when they give the Rogram because the mother is negative anyway.
Exactly, right? Because Rogram is basically to prevent antibodies. So it comes back negative the second time around. Yeah, we can give them Rogram. But they come back positive the first time, or in the second time, we can't give Rogram. It's not going to do anything. So yes, I'm happy. You said it all correctly. Yeah. So that's pretty much what this is. It's definitely a confusing process, but
So I'm so sorry. I have a question, Alicia.
okay.
So with the Coombs test, we always technically want a positive test. But if there is a negative test for the indirect Coombs test, that's when we're going to give Rogram the second time.
We want negative because positive means that the antibodies formed, which means the mom is fighting against the baby. The mom's blood is fighting against the baby. That's bad. We give Rogram to negative because no antibodies have formed yet, and Rogram's going to protect the baby from any potential antibodies being formed. When they form, there's nothing that you can do, but it's going to attack and destroy the baby's red blood cells. So positive is bad.
Okay, so we technically always want, well, no, we always want negative. And if it's positive, that's when we're gonna, I'm so confused. We always want negative, we always want a negative test, but if it's a positive, we're going to, well, no, if it's positive, we're going to leave the mom alone and just monitor. But if it's negative, we're going to administer Rogram just because that we caught on that the mom didn't form antibodies. So we're gonna give Rogram so she continues to not form antibodies.
Exactly. So first visit, we take their blood, we look at her Rh factor. If it's negative, okay, we're gonna run the indirect Coombs test. Indirect. So when we do the indirect test, it's gonna tell us either negative or positive. If it's negative, no antibodies formed. Great, but we can't trust that yet. We're gonna do that test again at 28 to 32 weeks. If it comes back positive, we know for sure that baby's Rh positive. Antibodies are fighting against each other. There's nothing that we can do other than surveillance. Came back negative, we repeat at 28 to 32 weeks. So if it's negative again, we give Rogram, as you said, to prevent antibodies from forming, so nothing attacks the baby. If it comes back positive in that second attempt, nothing we can do. Just watch out and, keep monitoring her.
So Alicia, when the mother is positive, we don't do nothing to them because we know we don't give Rogram when the mother is positive. So anytime the patient come in and then they are negative, that means that there's a chance of them forming antibodies later in their pregnancy, and you tell them to come back for another test, which is, so the test that they come back for to check for antibodies is basically the Coombs test.
Exactly.
Okay.
Exactly. Yes. So that's why this test, if the mom is Rh positive, who cares? Like, but if it says Rh negative, this is why we have to do this stuff. So yeah, like I said, first time around, we get the blood work. If she comes back Rh negative, we're looking at negative Coombs or positive Coombs. It's going to tell us negatives and say no antibodies formed, positives and say antibodies formed. If it's negative, right, we do a second round test between 28 to 32 weeks. If it's still negative, we give him Rogram. If it's positive, we just, like we did the first time, do nothing. Because if it came back positive that first round, we're not going to go for the second round of testing. It's only when it's negative that we're going to come back again at 28 to 32 weeks if the mom's Rh negative. Now,
I have a question too.
yes.
So if you were to since this is her first pregnancy and she didn't create any active antibodies, like do you just give it in general the second time she's pregnant?
So if she's Rh negative and we've done this, right? She gives birth, right? There was no antibodies formed. We're still going to give her Rogram. And actually, speaking about your question, here, I think this could answer it. So at delivery, right? The baby's born and we do a direct Coombs now, meaning we do it on the baby because we can get the baby's blood. That's what direct Coombs. Indirect is because we're getting it from the mom. Direct is because we're getting it from the baby, especially if we know that the mom was Rh negative. The mom was Rh positive, we don't need to do the direct Coombs. But at birth, well, if the mom was Rh negative, we're going to do a direct Coombs. We're going to get blood from the baby. If that mom, like you said, was unsensitized, did not form antibodies, gave birth to the baby, everything was fine, we're going to give the mom Rogram within 72 hours because they can form antibodies, right? And it could affect a future pregnancy. If the mom was Rh negative and the baby was Rh negative, no Rogram. Don't worry about it. The direct Coombs is going to tell us if the baby was Rh positive or Rh negative. And if there was no sensitization, right, there was no antibodies forming in the mom, we'll give her Rogram within 72 hours of delivery. Does that answer your question?
Yeah, it does. Thank you.
Okay, it can be confusing, but she's going to ask about these. So direct Coombs is on the baby, and we do that after the delivery. Indirect was when we were doing it on the mom because we didn't know what the baby is because we didn't have the baby physically with us to draw its blood. Okay. So I'm happy we got that down because that's a confusing thing, and you're going to get questions on that. Okay, so we talked about Rogram, and you give it intramuscularly. Okay. Now, there's one last part. You guys got up to chapter 20, right? In your thing for your test?
Yes.
Yeah.
Okay, so it's only like 2 pages of notes. Okay. So, we have diabetes, right? We know what that is. We know what the problem is that it's a disorder of carbohydrate metabolism. We have pre-gestational diabetes, meaning the mom got pregnant and she already had diabetes, either type 1 or type 2. Type 1 is always insulin deficiency, or they don't really have any, and type 2 is insulin resistance. So, their body doesn't really have a good ability of producing it, but it still has it. Then there's gestational diabetes, which is you get that when you're pregnant, and we'll get a little bit more into it. But you need to know there's problems if a mom has pre-existing type 1 diabetes. If a mom has pre-existing type 1 diabetes, they're at risk for a lot of different things, right? They could have a spontaneous abortion if that hemoglobin A1C is greater than 7.5%, because it should be lower than 7. She could also have DKA. It can cause polyhydramnios or too much amniotic fluid, hypertensive disorders, preeclampsia, postpartum hemorrhage, a bunch of problems, okay? For the baby, right, it can cause cognitive malformations if that hemoglobin A1C is greater than 7.5 in the mom, okay? It's really bad. And it could also even lead to neonatal hypoglycemia. If the mom has type 1 diabetes, instead of the congenital malformations, if it's greater than 7.5%, it's not the hemoglobin A1C that's high. If they have type 1 diabetes, the baby could be at risk for neonatal hypoglycemia, macrosomia, or a big baby, birth injury, hyperbilirurimia or jaundice, and delayed lung maturity. Okay, so there's a lot of problems when the mom has a high circulating flow of sugar. and no insulin receptors to take care of it. So preconception cares, they need a good glycemic control, a hemoglobin A1C of less than 7. Okay. First trimester is that insulin. This is what you need to know about insulin. She's going to ask you this. Antepartum, while she's pregnant, during that first trimester, the insulin needs are generally going to decline due to the secretion of placental hormones like progesterone and that HCG, which is that level that I said that increases especially during the first trimester of pregnancy, because of nausea and vomiting. So insulin needs decrease because of the progesterone and HCG increasing, causing nausea and vomiting. In the second and third trimester, insulin needs dramatically increase because HCG starts to go down and the body needs more. Okay, know this. During the labor process, we have a problem with potential neonatal hypoglycemia. To prevent hypoglycemia, actually, we will need a few different things. We actually need to have sugar. They need to have there needs to be an IV coming in with sugar, but the mom needs regular insulin. Because remember, a diabetic who's type 1 cannot never have insulin. They always need it. But the baby has a risk of having hypoglycemia as a result of this continuous regular insulin infusion during labor. So during labor, the mom needs continuous regular insulin infusion. It's the only one that's by IV. And there needs to be a solution running of sugar. And the sugar must be titrated between 70 and 110, okay? That's what the mom's levels need to be to prevent neonatal hypoglycemia in the baby. After the placenta is gone, postpartum, right after the placenta comes out, insulin requirements are going to drop rapidly, okay? So after delivery of the placenta, it should go back to pre-pregnancy levels. So you need to know these because she's going to ask about insulin. Okay, so think about it this way. First trimester, decrease. Second trimester, increase. For labor, mom needs insulin. We need to give glucose so that the baby's sugar doesn't get too low, and we need to titrate it and keep it between this number. Postpartum, when the placenta is gone, it drops again. So it's kind of like down, up, down. So then we have gestational diabetes, which is a type of diabetes that you see after or around 24 weeks gestation, okay? So basically what happens is that the pancreas here is not really able to meet the metabolic needs for insulin. High risk, right, is if they have a high BMI and a family history of gestational diabetes or even in other pregnancies. That's how we know they're at a high risk. A low risk, if they're at a low risk, we're going to start screening between 24 and 28 weeks, okay? So remember we were talking about diagnostic testing earlier? It comes back again. She's going to ask this, right? The 1-hour glucose tolerance test is a screening with 50-gram loaded of sugar. Nothing to prepare for, no fasting. Basically, if the level is equal to or greater than 130 to 140, after 1 hour of getting this 50-gram load, they need to go for diagnostic testing. This is a screening. The diagnostic is the 3-hour glucose tolerance test where we give a 100-gram load of sugar. Okay, so they go to the labs, they're told to fast after midnight, and they draw the labs. The fasting level, right? So the first thing that they're going to get is that 100-gram load, right? 1 hour, they're going to get that 100-gram load, but first they're going to check the fasting number. Then, after they get that fasting number, they're going to give them that 100-gram load, and then they're going to check what the number was at 1 hour, 2 hours, and 3 hours. Like I said, we said if 2 or more of these levels increase, they have gestational diabetes. So you need to know these numbers right here, okay? Greater than 95 for fasting, greater than 180 for 1 hour, greater than 155 for 2 hours, greater than 140. Any of those values are high, 2 or more, that's diagnostic for gestational diabetes. Okay, so for management, we're talking about, right, lifestyle, nutritional changes, things like that, a diabetic educator, right? We want to look at physical activity. They need tight glycemic control, a lot of glucose monitoring, okay? Fasting blood sugar should normally be for the mom less than like 90, all right, less than 95. 1 hour postprandial after eating should be less than 140. Okay. We also write priority, fetal kick counts, maybe non-stress tests, and BP. We already talked about when we need that. Insulin doesn't cross the placenta. That's why it's safe to give when a mom is pregnant. And we talked about the insulin needs already. Diet, insulin, oral diabetic medications, depending on what they need, right? And for intrapartum, we're looking at sometimes what we have to do is that they have to give birth by 39 weeks because the baby's just going to increase and it can increase complications with gestational diabetes. And postpartum, maternal insulin requirements. Remember, they said we decrease, right, especially after the placental delivery. So, and the diabetes will be gone. After the placenta is delivered, kind of like the same thing with like preeclampsia. When the baby's born, it goes away. When the baby's born and the placenta's gone, the gestational diabetes is going to go away, but they're at risk for developing type 2 diabetes later in life. Then the last thing I'm just going to really cover is the different infections and group B streptococcus. So just quickly, I'm just going to go over the really quick things that you need to know is that you need to know the pneumonic torch is a systemic infection, maternal infections. So we have toxoplasmosis. I want you to know that it's caused by a protozoan infection and that it's transmitted by this. It's transmitted to the fetus via contact with contaminated cat litter, consumption of raw undercooked meat, and contaminated soil. Okay? So you need to know this. And, right, of course, if they get this, any of these can cause problems with the baby, like abortion, things like that, cognitive changes. But the diagnosis to see if they have this will be IgM testing to let us know if they currently have it. And IgM tells us they have the disease. IgG tells you that they have antibodies and they may have had it in the past. So we want to do antibody tests with this. So antibody test. And how is it transmitted? Cat litter, raw, undercooked food, or contaminated soil. Hepatitis B, usually transmitted at the time of delivery. Okay, here's what we need to do. If it's detected through this hepatitis B surface antigen, we're going to do that test. If she is positive, meaning that she has hepatitis B, the infant must receive HBIG, which is delivery of antibodies. If the mom has it, you must give this first dose of hepatitis within 12 hours of delivery, this HBIG. Know that. Okay. And then the vaccine will be complete at, we'll complete the schedule at 1 month and then again at 6 months. Okay. Know that. For HIV, remember we said they have the right to refuse HIV, but in New York State, the baby must be tested. Okay. It's transmitted by body fluids and blood. Know that. Okay. And how do we treat it? We give antiretroviral therapy. Know this, that you're going to give IV Zyfodine 3 hours before a C-section at 38 weeks, depending on the viral load, if it's greater than 1,000, or during the labor of vaginal delivery. Know that you give this, okay? Just know. And no breastfeeding, right? When a mom has HIV because it can be transmitted through body fluids, okay? So that's your management. And that this Zydodine for the newborn, they get this for 6 weeks after as well. The newborn must get this for 6 weeks after to make sure that they're HIV negative. Rubella, right? We can get this through nasal, pharyngeal secretions and things like that, or even through the placenta. Women of childbearing age, we already said this earlier, diagnostic testing. They must be tested for rubella, tested for immunity, and they must be vaccinated before they become pregnant. She's going to ask about this, the titer. It needs to be 1 to 8 or greater indicates immunity. If they're not immune, they need to stay away from people who are vaccinated or have rubella. Okay, remember, the vaccine is contraindicated in pregnant women. Rubella is contraindicated. So you cannot become pregnant for 4 weeks after getting this vaccine. It can cause problems like congenital heart disease, hearing impairments, cardiac defects, if they get this vaccine. So remember, if they get rubella during this first trimester, they're at risk for a lot of problems. All right. And they can't get the vaccine while being pregnant, so they must get it before. And the titer must show that a 1 to 8 or greater indicates immunity. Know that number. Cytomegalovirus is a type of herpes. No, that's a type of herpes. It's widespread and pretty much affects everybody. It's the leading cause of congenital infection and perinatal viral infection in the world. First trimester, if they get it, it can cause spontaneous abortion. After that, it can cause a whole bunch of different problems. Primary prevention is avoiding anybody who has flu-like symptoms. Okay, so cytomegalovirus, know that it's very common to get, and that avoid people with flu-like symptoms. That's the only way you could do it. Okay. For herpes, right? It's RSV1 or RSV2, right? There are these lesions. We need a viral culture, right? Break the lesion, get fluid. Okay. If they have it during the first trimester, can cause an abortion for the baby, can cause preterm labor. So it has a problem. Significance is that here's what you need to know too. Vaginal delivery with no visible lesions or symptoms, they're not going to get the herpes. They're not going to get it. If there's no visible lesions and they're not open, they're not going to get it. Okay? Know how herpes is transmitted: vaginal, anal, oral sex, or skin to skin contact if that lesion is open. Primary outbreak, remember we have blisters, maybe enlarged lymph nodes, flu-like symptoms, difficulty urinating. But I would know, you need to know these medications. Anything that ends in "vir," and you need to know how much you give them, how many mg, and for how many days. She's very specific when it comes to these things. I know she asked about this. You can give aveclovir 400 mg orally 3 times a day for 7 to 10 days, or famicovir 250 mg orally 3 times a day for 7 to 10 days, or valacovir 1 gram orally 2 times a day for 7 to 10 days. You need to know this. You also need to know that there's no cure, and that if there's an outbreak, they need to have a cesarean delivery. Last but not least is the group B streptococcus, which is a naturally occurring bacteria in healthy people. It colonizes in the GI and GU tracts. Carriers, or people who have it and maybe aren't representing symptoms, could test positive, and you are at risk for receiving this as a baby going through the birth canal. Okay, so if they were to get group B streptococcus from the mom during birth, it can cause sepsis and meningitis in the newborns. And we also should treat UTIs, because UTIs can be caused by bacteria, and it could turn into this group B streptococcus, which can be very problematic for the baby. All pregnant women, know this, all pregnant women are screened at 35 to 37 weeks gestation. Antibiotics that we must give them prophylactically during childbirth. Okay, so if they are GBS positive, you're going to give penicillin G IV every 4 hours before birth and during labor. You must know what you're going to give them. I remember it wasn't like she didn't ask specifically that you give it every 4 hours, but it was like if the mom is GBS positive, what do? You need to give penicillin G IV. Okay? Know that. Know what medication you give. And for urinalysis, if you're looking at it, remember the S means that, hey, they're sensitive to this. This antibiotic is going to work for them. If that antibiotic or that says R, it means it's resistant to that. Not that antibiotic. So let's just say we're testing for different types of bacteria or whatnot, and we're testing different strands of antibiotics that may or may not work, right? If it's S, good. R, resistant, they should change the medication. If it says I, it could kill some bacteria, not at all, but we want to see an S. Is there any questions?